Hi, class. Today we're focusing on the foundation of every physical assessment, the general survey, vital signs, and pain assessment. And these may seem basic, but I want you to start reframing them. This is not just getting vitals, this is clinical judgment in action. Before we ever lay hands on a patient, the general survey begins the moment we walk into our patient's room. We're already noticing the level of distress, respiratory effort, body position, hygiene and grooming, affect and behavior. So that first 30 to 60 seconds really tells you a lot. Then we build on that with vital signs. And remember, vital signs are data, but data are meaningless unless we interpreted that within the context. So like a heart rate of 110 means something very different in a 22-year-old anxious college student versus an 84-year-old septic patient. And pain is considered the fifth vital sign, but it is subjective. It requires therapeutic communication, validation, and critical thinking. You're not just documenting a number, you're interpreting a physiologic and emotional experience. This entire unit connects back to clinical judgment. What are you noticing? What stands out as abnormal? How does it compare to baseline? What needs follow-up? General survey, vital signs, and pain assessment form the foundation for everything else we will assess this semester. So if you miss something here, you build the rest of your assessment on incomplete data. By the end of this lecture, I want you to think about not just collecting that data, but also analyzing it. Here are those student learning objectives today for this lecture. So when we talk about the general survey, we're talking about your first clinical impression before you touch the patient. And like I said, this begins the moment you see them for the first time, not when you put the stethoscope on, not when you open the chart, the very first time you visually engage with them. Your brain immediately starts processing. Are they in distress? Do they look comfortable? Are they anxious? Is their breathing labored? Are they sitting upright? Are they slumped over? Are they guarding something? That is the general survey. It begins at the first encounter, and this is important. It does not stop. It continues throughout the entire assessment. You're constantly reassessing. For example, if you walk in and the patient is talking in full sentences comfortably, that's data. If midway through your assessment, then they suddenly become short of breath, that's new data. You're continuously updating your mental picture. The general survey provides baseline data. It helps you answer, what is the patient's normal appearance right now? What stands out? What feels off? This is the foundation of clinical judgment, which is noticing. And many students underestimate the power of the general survey because it feels informal. But often the general survey is what tells you something is wrong before vital signs can even confirm it. If your patient just doesn't look right, that matters. So today, as we move into general survey components, start thinking like this. What am I noticing? What is expected? What doesn't match? Now let's break down what we are actually assessing during the general survey. There are 5 major components, and I want you to think analysis, not just observation. So let's walk through these together in the next slides. Physical appearance. Now, let's zoom in specifically on physical appearance. This is not casual observation. This is a structured clinical data collection. And I want you to think, what can I infer from each of these findings? Age. We always compare, does the patient's apparent age match their stated age? If someone looks much older than their stated age, think chronic illness, malnutrition, substance use disorder, advanced cardiopulmonary disease, severe stress, or socioeconomic strain. If someone appears younger than stated, usually not concerning, but document objectively. This is about noticing discrepancies. Sex. We note biological sex as observed or stated because it influences risk factors, it influences differential diagnoses, medication dosing, but we remain respectful of gender identity. I want you to also think, are there secondary sex characteristics that align with history? Any endocrine flags? Level of consciousness. Is the patient alert, drowsy, lethargic? Are they obtunded, confused? Level of consciousness is one of your most important early warning indicators. Changes here can signal hypoxia, sepsis, hypoglycemia, stroke, electrolyte imbalances, medication effects, so never ignore altered level of consciousness. Skin color we assess for pallor, cyanosis, jaundice, flushing, mottling, and this must be interpreted based on the patient's baseline pigmentation. For example, cyanosis is better observed in the lips, nail beds, and conjunctiva. Jaundice is better seen in the sclera, so skin changes can reflect respiratory compromise, anemia, liver disease, shock, or dehydration. Facial expression. This tells you, is the patient in pain? Are they having anxiety, depression, distress, fatigue, acute illness? Sometimes patients minimize verbally, but their face tells you the truth. Think about guarding or grimacing, flattened affect. Speech. Listen for clarity, rate, volume, coherence, appropriateness, or slurred speech. Can indicate stroke or hypoglycemia, intoxication. Do they have pressured speech? Are they having anxiety or mania? Slow speech, depression or fatigue, neurologic changes. Looking at this image, pause here and reference the slide. What do you see? An older adult, their hand to their forehead, eyes partially closed, neutral to fatigued expression, lying in bed. What hypotheses could this generate? Are they in pain, fever, fatigue, headache, stroke, dehydration? The goal is not to diagnose, the goal is to generate possibilities, and that's clinical judgment. Now we move from general appearance to something more measurable, which is body structure. This is where observation meets objective data. Height. Height isn't just a number, it helps us calculate BMI, track pediatric growth curves, detect abnormal growth patterns, identify endocrine disorders, identify skeletal abnormalities. In older adults, for example, loss of height may indicate osteoporosis or vertebral compression fractures, kyphosis. So always compare to prior records if available. Weight. Weight must be interpreted in context. So ask, is this baseline? Has there been any recent changes? Are they intentionally or unintentionally losing weight or gaining weight? It could indicate malignancy or even hyperthyroid, depression, malnutrition, where on the opposite end, rapid weight gain could indicate fluid retention or heart failure or renal disease. Nutrition status, which looks beyond BMI, so we assess muscle mass, fat distribution, temporal wasting, skin turgor, hair quality, edema. A patient can be overweight and malnourished. A patient can appear thin but be metabolically stable. This is also pattern recognition. Symmetry, comparing the left to the right. Are the shoulders level, muscles equal, limbs symmetrical? Because asymmetry may indicate stroke, neuromuscular disorders, atrophy from disuse, injury. Posture, normal posture, are they erect? Are they relaxed? Are they with even alignment? Abnormal posture may suggest chronic pain or Parkinson's, kyphosis, scoliosis, even respiratory distress when our patients are in tripod position. Posture often reveals discomfort before the patient even states it. And then body proportions. Are proportions age appropriate? Disproportionate findings may reflect genetic disorders, Marfan syndrome, which patients have long limbs, hormonal disorders. In pediatrics, proportions are critical. In adults, changes over time matter more. Mobility. Mobility tells us how well structure and neurologic control are working together. If body structure was about form, mobility is about function. So gait, coordination, movement, impairment, assistive devices. When you assess mobility, don't just ask if they can walk, you should watch them walk and observe smoothness of their gait, balance, how their arms are swinging, their base of support, and the speed in which they are walking. Abnormal patterns can point out to Like they have shuffling gait, maybe they have Parkinson's disease. A wide base gait could be cerebellar dysfunction. Hemiplegic gait could mean stroke. So ask, do they use a cane, walker, a brace? Is it used correctly when they demonstrate that? Is it a fall risk? Assistive device use tells you baseline function, risk for injury, and degree of independence. So mobility is really about safety. Posture overlaps with body structure, but here we consider it during movement. So look for any guarding, forward leaning, rigid posture, or asymmetry. Posture during ambulation can reveal pain, muscular weakness, respiratory compromise, like tripod positioning we talked about, and neurologic disease. Range of motion, active versus passive range of motion. Active range of motion is when the patient moves independently, whereas passive is when the examiner moves the limb. So reduced range of motion may suggest arthritis or injury, muscle weakness, contractures, neurologic deficit. So listen for crepitus as you're moving the arm or as they are moving themselves, pain with movement, resistance. Range of motion is one of the first things lost in immobility and aging. Behavior and hygiene. This is part of your first impression of the patient, what you observe before you even touch them. And your book emphasizes that these observations provide critical baseline data about physical, emotional, and cognitive status. So dress appropriate for settings. Assess whether clothing is appropriate for the weather, setting, and situation. You want to look for overdressing or underdressing. It may indicate cognitive impairment, mental health concerns, or socioeconomic factors. So things like a hospital gown worn incorrectly, maybe possible confusion or even distress. Hygiene, we want to observe for cleanliness, grooming, body odor, hair, nails. Poor hygiene may indicate depression, cognitive decline like dementia, physical limitations, or lack of access to care. And then excessively meticulous hygiene could suggest anxiety or even OCD tendencies. Mood and affect. So mood is what the patient tells you, and it's subjective. Affect is what you observe. It's objective expression. So assess for appropriate versus inappropriate affect. Are they flat, or do they have blunted or labile affect? Eye contact. This indicates engagement, comfort, and emotional state. So avoidance of eye contact could mean anxiety, depression, or it could also just be a cultural norm. And intense staring could mean possible mania, aggression, or a neurologic issue. So always interpret eye contact in cultural context as well. Distress, we want to look for visible signs of discomfort or pain, like facial grimacing, guarding, restlessness. Remember, patients may underreport pain, so your observation is going to matter here. We want to connect to pain assessment and safety priorities. And then interaction with the environment. Assess how the patient relates to you as the nurse, family members, and their surroundings. Are they withdrawn? Are they agitated or restless? So now we're going to go into a vital sign overview. So let's start with temperature. So temperature is a key vital sign that reflects the body's ability to maintain homeostasis. Even small changes can signal infection, inflammation, or environmental exposure. So the normal range is 37 degrees Celsius or 98.6 degrees Fahrenheit. So expected range, depending on the person and the site, is 96.8 to 100.4 degrees Fahrenheit or 36 to 38 degrees Celsius. And there are variations, right? Like circadian rhythm could, their temperature could be lower in the morning, higher in the evening. Age, older adults may have lower baseline temperatures. So a normal temp in an older adult may still indicate infection if it's elevated from their baseline. Sites in which we can get temperatures, oral, tympanic, rectal, temporal. So oral being the most common, convenient. We want to avoid if the patient is confused, unconscious, or has oral surgery, or if they've just drank something like really hot or really cold. Tympanic, this reflects core temperature if positioned correctly, but it can be inaccurate with poor technique or earwax. Rectal, this is the closest to core temperature. It's higher than an oral temperature by about 0.5 to 1 degree Fahrenheit. We do want to avoid this in neutropenia, rectal surgery, or bleeding risk. Temporal, this is non-invasive, it's quick, but it can be affected by sweating or the environment. And when you're obtaining a temperature, you want to maintain consistency with the same site when you're trending the temperatures. Fever versus hyperthermia. So fever, this is a controlled rise in temperature due to infection or inflammation. And the body resets its thermostat via the hypothalamus. It often responds well to antipyretics like acetaminophen if there is a fever, whereas hyperthermia is uncontrolled increase in body temperature. The hypothalamus is not going to go ahead and reset it. Examples of this would be heat stroke or malignant hyperthermia, and that indicates a medical emergency when it doesn't respond to antipyretics. And then hypothermia, which is defined as less than 95 degrees Fahrenheit or 35 degrees Celsius. Causes include environmental exposure to cold, shock, alcohol, or CNS depressants. So clinical signs, early signs would be shivering, confusion, bradycardia, decreased respirations would be more late signs. And severe hypothermia can lead to cardiac dysrhythmias and death. Pulse reflects the mechanical activity of the heart, specifically blood ejected into the arterial system. So pulse sites, we assess pulse at multiple arterial sites depending on the situation. We have radial, which is done routinely via vital signs. Apical, which is most accurate, and it's used for irregular rhythms or medications like digoxin or metoprolol. Carotid, we utilize this in an emergency when we are about to perform CPR or even central perfusion in the ICU setting. Brachial, which we use on infants. We also have femoral, popliteal, posterior tibial, dorsalis pedis to assess peripheral perfusion. And I want to emphasize that we should always be comparing bilateral pulses when we do assess circulation. Pulse rates, normal for adults is 60 to 100. There are variations though. We have tachycardia, which is over 100, may indicate the patient has a fever, pain, hypovolemia, or anxiety. And then bradycardia, which is less than 60 beats per minute. We might see this in athletes. Patients are taking medications like beta blockers or digoxin, and conduction issues. So always consider the context, not just the number. Rhythm, we want to assess if the pulse is regular, which means it's consistently spaced out, or irregular, which could indicate dysrhythmias like atrial fibrillation. If it is irregular, you should assess an apical pulse for a full minute. Strength, this reflects the force of cardiac contraction and arterial tone. So we use the 0 to 4 plus scale. 0 means absent, which is an emergency. 1 plus is weak, thready, could indicate shock or low volume. 2 plus is normal. 3 plus is strong. And then 4 plus is bounding, which could mean fever or even hyperthyroid. So usually weak pulses are tied to poor perfusion, and bounding pulses are tied to increased cardiac output states. And then, like I said, symmetry, we always want to compare pulses side to side. Equal is obviously expected, and unequal could indicate possible arterial obstruction or vascular disease. Respirations reflect both respiratory and metabolic function and are one of the most sensitive indicators of patient deterioration. So any changes in breathing often occur before other vital signs change. The rate, normal adult would be 12 to 20 breaths per minute. So abnormal findings would be tachypnea, where we have respirations over 20, could indicate anxiety, pain, hypoxia, fever, acidosis. Or we have on the opposite end bradypnea, which is a respiratory rate less than 12, could indicate opioid use or CNS depression. So always count for a full minute if irregular or if you're concerned. The pattern should be regular, consistent. If it is irregular, it may indicate neurologic or metabolic issues. So abnormal patterns, we might see Cheyne-Stokes breathing, alternating deep, shallow with periods of apnea, and we do see this in neurologic injury. We see this at end of life. We can also see this in heart failure patients. Kussmaul breathing, which is deep, rapid breathing due to metabolic acidosis when patients are in DKA, diabetic ketoacidosis. And then we're assessing depth, how much air is moving. If they have shallow respirations, they are hypoventilating, they might have pain, fatigue, or they're using opioids, or they're medicated with opioids. Whereas deep is hyperventilating, where they might have anxiety or acidosis, like we just talked with Kussmaul breathing. So depth is just as important as rate. So fast but shallow breathing may still mean poor oxygenation. And then effort, we want to look for work of breathing. Normal is quiet, effortless, no accessory muscle used. Increased effort signs, though, like nasal flaring, use of accessory muscles. We see their neck or intercostals start to retract, or even tripod positioning may be early or later signs of respiratory distress. Blood pressure. Blood pressure reflects the force of blood against arterial walls, and this is a key indicator on vascular health and perfusion. Accurate technique is really critical here. Many errors come from improper measurement. So proper cuff size directly impacts accuracy. So guidelines, we want the bladder width equal to 40% of the arm circumference and the length 80% of the arm circumference. So when we get too small of a cuff, we can have a falsely high blood pressure. And on the opposite end, if we have too large of a cuff for that patient, we get a falsely low blood pressure. So we always want to check the patient's arm size, especially in pediatrics and obese patients. Arm positioning, we want to keep the arm at heart level, supported, not hanging. If it's below the heart, we can get a falsely high reading, and if it's above the heart, we can get a falsely low. We want them to rest for 5 minutes before we measure it. Avoid caffeine, smoking, or exercise beforehand. Systolic versus diastolic. So systolic is the top number, which is the pressure during ventricular contraction, and diastolic is the pressure during ventricular relaxation. So when we do measure this, we hear the first sound, which is systolic, and the disappearance of the sound is diastolic. We also have orthostatic measurements, which are used to assess volume status and autonomic function, where we have the patient lying supine for 5 minutes. We grab a blood pressure as they are supine, and then we have them sitting for 5 minutes, grab it then, and then standing after 1 to 3 minutes. So a positive orthostatic hypotension would be a decrease in systolic greater than or equal to 20, and then a decrease in diastolic greater than or equal to 10. So symptoms of orthostatic hypotension could be dizziness, lightheadedness, syncope, important in older adults, dehydration, and medication effects. Oxygen saturation, which measures the percentage of hemoglobin bound with oxygen. It's a quick, non-invasive way to assess oxygenation status. It does not measure ventilation or CO2 levels, though. So normal range is 95 to 100% in healthy adults. Clinical considerations, though, greater than or equal to 90% is often acceptable. In some chronic lung diseases like COPD, we actually would like this more in the range of 88 to 92% oxygen saturation. And when you get to adult health 2, we'll talk more about this. And I actually think you're going to talk about this in adult health 1. But anything below that as expected baseline should always be investigated. Factors that affect accuracy. Pulse oximetry depends on adequate perfusion and proper sensor placement. So some common causes of inaccurate readings include motion, like shaking or tremors, probe placement that is poor, or ambient light interference. Wow, I can't speak. So always assess the patient, not just the number. Good perfusion is required for an accurate reading. Poor perfusion situations like shock, hypotension, peripheral vascular disease. If perfusion is poor, the reading may be falsely low or even inconsistent. Nail polish or cold extremities, especially nail polish that is dark in color, can interfere with the sensor. And then cold extremities, which cause vasoconstriction, can cause decreased signal. So some solutions here: remove the nail polish, warm the extremity, or use alternative sites like the earlobe or forehead. Pain. Pain is considered the 5th vital sign because of its major impact on patient outcomes. And pain is whatever the patient says it is. It's inherently subjective. It can't be directly measured, so we rely on patient self-report. Even if the patient appears comfortable, if they say it hurts, we are going to believe them. This is foundational to patient-centered care. And we want to use validated scales. We want to choose based on the patient, whether this be the numeric scale 0 to 10, which is the most common, the Wong-Baker FACES for pediatrics or communication barriers, or the FLAC scale used for nonverbal patients. And we want to use a consistent validated tool for accurate reassessment as well. Cultural influences. Pain expression varies widely across cultures. Some patients may minimize pain or may be more expressive about their pain. So we want to avoid bias and assess each patient as an individual. We want to assess location, quality, severity using the PQRST or old carts. This helps us identify underlying causes and guides our treatment. And then we have types of pain like acute pain, which is sudden, short, chronic pain that lasts greater than 3 months. It's often more complex. We have nociceptive, which is all about tissue injury, somatic versus visceral. Neuropathic, which is nerve-related, where we might hear that they're having burning or tingling. So different types respond to different treatments. So it's important we assess the type of pain that they're having. And then sources of pain can include injury or inflammation, surgery, chronic disease, also considered referred pain or psychological components. Pain is often multifactorial. So because pain is subjective, we need structured, consistent tools to assess it accurately. Jensen emphasizes using both assessment frameworks and validated scales to fully understand the patient's pain experience. So we talked about old carts, which is onset, location, duration, characteristics, aggravating factors, relieving factors, timing, and severity. OPQRST is very similar. And then we have the numeric rating scale, 0 to 10, 0 being no pain, 10 being the worst imaginable, best for alert-oriented patients. We have the verbal descriptor scales, which uses words like mild, moderate, or severe, helpful for patients who struggle with the numbers. We also have an Iowa pain thermometer, which is visual and verbal descriptors. It's useful for older adults. the Wong-Baker Faces Scale, which uses facial expressions. It's ideal for pediatric patients, patients with language barriers or cognitive impairment. So we want to choose the right scale for the patient and, again, use it consistently. Lastly, let's talk about functional status and objective measurements. So height and weight, these are foundational measurements that provide insight into a patient's overall health status, nutrition, and their disease risk. So we want to use these as baseline data points that we trend over time. So a baseline measurement, we want to obtain the height once in adults unless their condition changes, and their weight every visit or hospitalization. Best practice is to use the same scale, same time of day, or similar clothing. Daily weights are especially important in conditions like heart failure or fluid imbalance. And then BMI calculation, which is their weight in kilograms over their weight in height, their weight in kilograms over their height. Categories, underweight is less than 18.5, then normal 18.5 to 24.9, overweight 25 to 29.9, and then obesity greater than or equal to 30 for a BMI. And this is a screening tool. It's not a diagnostic tool. It doesn't account for muscle mass or weight distribution. Unintentional weight loss or gain, this is a red flag in assessment. So any concerning findings like greater than 5% loss in a month or greater than 10% loss in 6 months. Possible causes, we know weight loss, unintentional weight loss, cancer, but it could also be things like hyperthyroid, depression, or malnutrition. Whereas weight gain, we think about fluid retention and heart failure, or renal disease, or even endocrine disorders. But we always ask, was this intentional? So we just talked a little bit about BMI, but BMI is a quick, widely used screening tool to assess weight status and potential health risk. And Jensen reminds us that BMI should always be interpreted along a full nutrition assessment, not in isolation. So we talked about a normal BMI on the last slide, but normal is 18.5 to 24.9. And this is associated with the lowest risk for chronic disease in most adults. Again, we want to emphasize that this is a guideline. It's not a perfect measure for every patient. And then underweight BMI less than 18.5, possible concerns would be malnutrition, eating disorders, chronic illness like cancer, hyperthyroid. Assessment considerations, we want to assess their dietary intake, their muscle mass, their energy levels. These patients are at high risk for impaired immunity and delayed healing. Overweight patients, BMI 25 to 29.9. Associated risks with this, hypertension, type 2 diabetes, and cardiovascular disease. There are different obesity classes. Class 1 is 30 to 34.9. Class 2 is 35 to 39.9. And then Class 3, which is the most severe, is greater than or equal to 40. So the risks increase with each class of, cardiovascular disease, sleep apnea, metabolic syndrome. So in this case, we do want to evaluate the distribution of fat, not just the total weight. And that brings us into a broader nutritional assessment. So again, BMI is just one piece of the puzzle. We also assess their diet history, a 24-hour recall, any appetite changes. We're going to grab some blood and get lab values like albumin, prealbumin. And then physical signs. Is there muscle wasting or is there edema? Is the patient getting adequate nutrition for their needs? General nutrition status, we want to get their overall nutrition status through physical exam findings. These can help us identify if they are malnourished, if they do have chronic disease or a fluid imbalance. So assessing their muscle mass, muscle wasting or loss of tone. Do they have prominent bones like temples, clavicles, shoulders? Are they really popping out? It's common in malnutrition or chronic illness or even aging sometimes. So muscle loss is often one of the earliest signs of poor nutrition. fat distribution, we want to observe, is it even versus uneven fat distribution? Do we have loss of subcutaneous fat, like there's a sunken appearance to their face? Is there excess central adiposity, so abdominal fat? So again, loss of fat could equal malnutrition, where central obesity increases their cardiovascular risk. Skin and hair condition, is their skin dry and flaky? Could indicate dehydration or nutrient deficiency. Do they have poor wound healing? Could indicate a protein deficiency. Is their hair dull, brittle, or thinning? Could mean possible malnutrition. These are subtle but important external indicators of internal nutrition status. And then we want to look for edema, which is the presence of swelling, especially in lower extremities. It can indicate protein deficiency, like a low albumin level, heart failure, or renal disease. So edema can mask weight loss. A patient may appear heavier but still be malnourished. So that's why we kind of look at that. These are priority findings you should recognize immediately during your general survey. These are cues often that signal clinical deterioration, and they'll require prompt action. Altered level of consciousness, so any change from baseline like confusion, lethargy, unresponsiveness. We always want to prioritize airway, breathing, and circulation. So any labored breathing, signs of use of accessory muscles, retraction, nasal flaring could indicate respiratory distress. That's a red flag. Cyanosis, bluish discoloration of the lips, nail beds, or skin can indicate low oxygen levels, so hypoxemia. Extreme distress can be from physical pain, respiratory distress, or emotional, like panic or anxiety, restlessness, agitation. Inability to ambulate. So if this is new or sudden inability, like weakness or a neurologic deficit, that's a red flag. Safety concern also is a fall risk. Cachectic appearance, which is severe weight loss with muscle wasting and prominent bones. This is associated with cancer, chronic illness, or malnutrition. This indicates advanced disease or severe nutritional deficiency. All red flags. So the general survey, it's not just our observation, it's the foundation of clinical judgment. And your book emphasizes what you see first should really guide what you do next. What are you noticing? You want to start with objective observations. What do you see, hear, sense? You want to avoid jumping to conclusions. You want to focus on how you're describing these things, not interpreting them yet. What patterns do you see? Now we're connecting the dots. We want to ask, do findings cluster together? Example, tachypnea, restlessness, low O2 could mean possible hypoxia, whereas weight gain, edema, shortness of breath could mean possible fluid overload. You know, we're recognizing patterns, not just isolated findings. What requires immediate action? We're going to always prioritize the ABCs, airway, breathing, circulation. And then what can wait? Not everything is urgent. We want to prioritize safety. So examples, stable chronic findings, mild discomfort. This helps prevents task overload and improves our decision making. And then putting it all together. Clinical judgment is really a process. It's going to take some time to understand it, but we're recognizing cues with our general survey. We're analyzing the patterns and we're prioritizing our actions, and then we're evaluating our outcomes. So that's it for our lecture on general survey vitals and some red flag information. Can't wait to see you in class for activities. Have a great day.